Very good afternoon, Chairperson and delegates and my co-speakers. So I will just talk about the principles and techniques of transforaminal endoscopic discectomy. Transforaminal, the philosophy has evolved because of this. Whatever tissue we preserve is going to help us in improving the function. So the tissue preserved is going to be function preserved. The approach, how we do it, you have to target the pathology and at the same time the anatomy has to be preserved. So there are different ways of targeting the pathology based on the location of the pathology. It can be accessible through an interlaminar approach or a transforaminal approach based on the location of the pathology. So you need to know where the pathology is located and plan your treatment. For a transforaminal approach, the anatomy which you should be familiar with would be the Campbell's triangle. Why is it? Because we are going through the foramen, which is a natural foramen, which is the nature-provided foramen. We don't have to create a foramen to access the tissue which is damaged. This is formed by the exiting nerve, the Campbell's, the lateral border, and the medial border by the thecal sac, and inferiorly by the pedicle and the inferior end plates. So this is the best because, as I said, the natural existing foramen is utilized to access the pathology and the least traumatizing of all the procedures to access the damaged tissue. The pathology, the target angle will vary, whether it has to be steep. When, for example, your approach is going to be very steep when you have an extraforaminal approach, or you're going to have, let us say, a discitis or a pathology which is damaging the disc. You need to take some tissues or debride the tissues from the end plate to disc space. You would use a more vertical approach. And for a large extruded fragment or which is predominantly into the canal, you would like to keep the scope more shallow and get into the predominantly your view of the canal rather than the disc space. So you need to have a fairly good idea of the scope, because once you reach the spot, it's all about how you handle your instruments and how you use your cannula. This is what you need to understand, because this is all in one. You have all the working channel through that, the visualizing structures through that. You have the irrigation also. The best part of this transforaminal full endoscopic technique, you have the irrigation system as well, which makes the visualization of the structure as it is without interference of the bloody field. And the instruments are all well designed, which has got right from the straight instruments to the angular instruments as well as the articulated instruments. They have the similar to the open procedures, the Kerisons, the disc punches, and the micro punches and very handy instruments to clear the tissues. And the most important part is the bleeding control with the radiofrequency probe, which is also a flexible probe, without which the surgical procedure will get defeated. So you need to follow the steps. It has to be a step-by-step approach. First, you have to draw the lines. What we follow is these lines. We have to know which level we have to access. When we mark the orthogonal position on the AP view on the midline, the next you have to rotate your C-arm, identify the superior aspect. Is the topmost level would be the spinous process level, the top line, and the bottom line would be the ascending facet line, below which you should not go. So the red would be the bottommost level which you can use to access the transforaminal route. And the topmost which we use is the spinous process strip on a lateral view once you have marked the AP view. And this, as I said, is a coaxial discectomy. So whatever you do has to be based on once the needle is landed there and anchored on that particular spot, you're going to follow the same track. So you need to place the needle right on the target, that is the disc. And if you predominantly we like to have it on the medial aspect of the pedicle, on the AP view, and the lateral we want it on the posterior aspect is exactly what we want, is to touch the posterior aspect of the vertebral body. And then you start introducing the dilator. The dilator advantage is, as you know, that it is not going to cut any tissues. The tissues are going to be distracted and pave way for the cannula to come in. Once the cannula comes in, and it's going to be followed by the endoscope. And this endoscope is the one which is able to help you to visualize the structures and the grasping instruments to relieve the pathology from that problem area. This is a short example of a case we had presented with the left side sciatica, with hardly not able to lift the leg more than 30 degrees before we shifted him to theatre. And the X-ray shows he's got a scoliotic spine. And when you look at the X-ray, we look at whether it is accessible for a transforaminal route or interlaminar approach. Here, the iliac crest is fairly at a lower level, so it means that we can access the L4, L5 through transfemoral route. The MRI showed there is an inferiorly migrated disc fragment which is extruded on the axial views, and what we did was a transfemoral approach to remove the disc fragment in total, almost 1.5 centimeter size of disc material, and he had got back his straight leg raising back to normal on the table on the same day. This is what we could achieve through our transfemoral approach, and barely any scar. This is a small reward for the procedure. We have to search for the scar at the end of the day. And to conclude, use an approach which is the least traumatizing to the tissue and which is safe. The pathology has to be addressed effectively. Learn the technique step by step, use it step by step. Use what works best in your hands. Thank you very much.